I'm Dr. Alan Bongat from the Department of Internal Medicine, and today I'll be discussing alcohol-associated liver disease, non-alcoholic fatty liver disease, and cirrhosis and its complications. People drink alcohol for a variety of reasons. Maybe for fun, maybe to unwind and relax, maybe to celebrate, and many more other reasons. But if there is an impaired ability to stop or control alcohol use despite harmful consequences to health, relationships, or work, then that is alcohol use disorder. Alcohol use disorder represents a spectrum from mild to severe based on how many symptoms are present. Now, when is alcohol too much? So, by quantity, alcohol use disorder is defined as more than 2 drinks per day in women and more than 3 drinks per day in men. Or binge drinking, which is defined as 4 drinks for women and 5 drinks for men in a span of 2 hours. Take note that 1 drink equals 14 grams of ethanol, which is also equal to 1 beer, 4 ounces of wine, or 1 ounce of 80% spirits. Alcohol-associated liver disease comprises a spectrum of diseases associated with chronic alcohol consumption, ranging from alcohol-associated fatty liver disease to steatohepatitis and to more advanced liver disease such as fibrosis and cirrhosis. And having cirrhosis is a major risk factor for hepatocellular cancer. Acute alcoholic hepatitis is an acute on chronic form of alcohol-associated liver disease that is associated with liver failure and has a very high mortality. Alcohol is oxidized into acetaldehyde, which is a toxic compound. During alcohol breakdown, there is an increase in the production of NADH, and the high NADH would disrupt the liver's normal metabolism. So there will be increased lipogenesis and decreased fatty acid oxygenation, resulting in hepatic steatosis. Alcohol metabolism also generates reactive oxygen species causing oxidative stress, which causes hepatocyte injury. And the reactive oxygen species, along with acetaldehyde, also react with cell membranes, leading to lipid peroxidation, which damages the hepatocytes further. Now, when the hepatocytes are injured, damaged hepatocytes release cytokines and attract inflammatory cells, so there will be more inflammation and more cell injury. And aside from this, there is Kupffer cell activation. They are activated by gut-derived endotoxins from increased gut permeability caused by alcohol. And when the Kupffer cells are activated, they release cytokines like tumor necrosis factor and cause further liver injury. In response to liver injury, the hepatic stellate cells become activated and they start producing collagen and extracellular matrix, which then leads to fibrosis and eventually cirrhosis if the injury continues. Now, if you are wondering why women are more susceptible to alcohol-induced liver injury than men, even at lower levels of alcohol intake and shorter duration of drinking, it is because of this alcohol dehydrogenase. So the majority of ethanol is oxidized via alcohol dehydrogenase into acetaldehyde, and women have lower activity of gastric ADH, which is the enzyme that metabolizes ethanol in the stomach before absorption. So this means that more unmetabolized ethanol enters the bloodstream even after drinking the same amount. Among patients with significant alcohol intake who develop hepatic steatosis, only around 10 to 20% will develop progressive liver disease and cirrhosis. And these are the risk factors for progression. So, The more amount of alcohol intake, of course, the greater the risk. Again, for women, the tolerance is lower, so more than one drink for women and more than two drinks for men would increase the risk of progression. The drinking pattern is also important, no? So binge drinking and alcohol drinking outside of meals increases the risk of developing progressive alcohol-related liver disease. There's also a genetic predisposition to alcohol-associated liver cirrhosis. Again, as mentioned, females are more at risk even with lesser amount of alcohol intake. Smoking also is a risk factor for progression of alcohol-associated liver disease, as well as increased body mass index. So overweight or obese people and those with other chronic liver diseases such as viral hepatitis, hemochromatosis, even non-alcoholic steatohepatitis are also contributing factors to progression of alcoholic liver disease. And lastly, some patients with alcohol-associated liver disease have changes in the gut microbiome and increased permeability, intestinal permeability, resulting in activation of hepatic inflammation, hepatocyte death, and activation of fibrotic pathways. These are the signs and symptoms of alcohol-associated cirrhosis and alcoholic hepatitis. It is important to note, though, that even with steatosis, steatohepatitis, or even compensated cirrhosis, or those with cirrhosis but with no complications, patients can still be asymptomatic. So only if they develop acute decompensation or alcoholic hepatitis will they have symptoms. So one of the often overlooked symptoms is tiredness. So patients would initially complain of only getting easily fatigued. And then later on, they can have signs of malnutrition, muscle wasting, they can have abdominal, skin, or eye findings. And I'll be discussing more of this later in the topic of cirrhosis. Alcoholic hepatitis is an acute inflammatory liver injury caused by chronic and excessive alcohol consumption. Patients with alcoholic hepatitis have been drinking heavily for typically more than 5 years and at least 8 weeks before the onset of symptoms. So this means that individuals can still have alcoholic hepatitis even if they have recently stopped drinking alcohol. The usual presentation is jaundice, often with other signs and symptoms such as fever, body malaise, tender hepatomegaly, and clinical signs of hepatic decompensation such as ascites, bacterial infection, variceal bleeding, and hepatic encephalopathy. Infections occur often in patients with severe alcoholic hepatitis at the time of admission. So alcoholic hepatitis is often accompanied by systemic inflammatory response syndrome and acute kidney injury secondary to hepatorenal syndrome. These are the laboratory findings of patients with ALD. So for alcoholic steatosis, patients can have normal liver function tests. But with steatohepatitis, there will be elevated AST and GGT, and the characteristic laboratory parameters for ALD will be seen here. So this is the ratio of AST to ALT being more than 1. This is because AST is present in both mitochondria and cytoplasm, and ALT is mainly cytoplasmic. So when there is alcoholic liver injury, the damage is primarily in the mitochondria, leading to release of mitochondrial AST into the bloodstream. So this gives a disproportionately higher AST levels, but the AST levels actually does not exceed 300 IU per liter. Serum bilirubin and INR are typically normal during this time, but with progression to cirrhosis, there will be elevated bilirubin and INR and low serum albumin and low platelet count. Patients with alcoholic hepatitis have AST and ALT levels that are elevated but do not exceed more than 400, and the ratio is of AST to ALT is a bit wider, more than 1.5, and the serum bilirubin is elevated at more than 3 milligrams per DL. We can use the audit for identifying patients with alcohol use disorder. This is a 10-item screening questionnaire developed by the WHO to identify hazardous and harmful drinking patterns, including those that can lead to alcohol, liver disease, and other alcohol-related health problems. Alcohol-associated steatosis can easily be seen on simple ultrasound, on magnetic resonance imaging, or computed tomography. The percentage of fat in the liver can also be quantified with the ultrasound technique of controlled attenuation parameter, or CAP, or with magnetic resonance proton density fat fraction. Progression of alcohol-associated steatohepatitis to fibrosis can be diagnosed using liver stiffness measurement by techniques such as transient elastography or fibroscan. And if the stiffness is at least 8 kPa, so that would mean advanced fibrosis, or F3. And if it's more than 12.5 kPa, that indicates cirrhosis. These imaging tests actually check for the presence of steatosis or fats in the liver, but does not really determine who among these have alcohol-related liver disease. So you still have to identify who have the risk factors for ALD, and you still have to rule out other possible causes of the fat accumulation. Liver biopsy is rarely indicated for the diagnosis of alcohol-associated hepatic steatosis or steatohepatitis. But if done, liver biopsy typically shows hepatocytes with large lipid droplets or macrovesicular steatosis. For those with steatohepatitis, there will be hepatocyte injury and ballooning with Mallory-Denk bodies, necrosis, and lobular inflammation with mononuclear and neutrophilic granulocytes. If with fibrosis, histology would show perivenular fibrosis initially, with subsequent extension of collagen fibers into hepatic lobules. But liver biopsy would be most helpful for alcoholic hepatitis if the diagnosis is uncertain, because treatment is warranted and proven for cases of alcoholic hepatitis. So for alcoholic hepatitis, histology would show macrovesicular steatosis, hepatocyte ballooning with Mallory-Denk bodies, megamitochondria, neutrophil infiltration, bilirubinostasis, and chicken wire fibrosis. There's currently no approved drug for the treatment of ALD. The management depends on the stage, but in general, the most important is alcohol abstinence. Those individuals who have fatty liver or even steatohepatitis due to alcohol can have a complete resolution with abstinence. Even for those who already have cirrhosis, abstinence can reduce complications and even improve survival. These are signs of hepatic decompensation, and we try to prevent them. For example, if there's already a portal hypertension, we can give beta blockers to reduce the portal pressure. So management of these complications will be discussed later. And for those who have alcohol-associated cirrhosis with decompensation, liver transplant is the definitive therapy, and ALD is currently the leading indication for liver transplantation in the United States. So liver transplantation evaluation should be taken into consideration for patients with end-stage liver disease. Let's now go to the treatment of alcoholic hepatitis. When we suspect alcoholic hepatitis, first, if the diagnosis is in question, like if there are confounding factors such as the presence of viral hepatitis or other liver conditions, then it is best to do a liver biopsy. If clinically it is alcoholic hepatitis, we check if it's moderate or severe using either the Madrid discriminant function or MDF or the MELD score. So, using these scoring systems, short-term mortality can be predicted. So for the MDF, your parameters would be the protime and the bilirubin. And for MELD score, your parameters would be bilirubin, INR, creatinine, and sodium. So if the MDF is less than 32 or you have a MELD score of 20 or below, this is defined as having moderate alcoholic hepatitis. So the treatment for this will be mainly supportive. So alcohol abstinence and nutritional support. So the recommendation is at least 21 kilocalories per kilogram per day and supplementation of micronutrients, particularly zinc, and vitamin supplementation, particularly B1. So if there is a need for volume expansion, it is best to use intravenous albumin. Patients with MDF of at least 32 or a MELD score of more than 20 have a high mortality rate, and these patients could benefit from glucocorticoids because glucocorticoid use reduces the risk of death in patients with severe alcoholic hepatitis within 28 days of treatment. So the steroid of choice is methylprednisolone or prednisolone. But if unable to take oral meds, then the preparation is methylprednisolone. Again, the best choice of steroid would be an oral form, prednisolone. But if unable to take oral form or oral meds, then you can use IV methylprednisolone. So after this, we check for the Lyle score. So this will be the basis for either continuing the steroids for 28 more days or 28 days in total, or discontinuing prednisone and instead consider liver transplantation. So for the Lyle score, the parameters are age, baseline bilirubin, day 7 bilirubin, albumin, creatinine, and prothrombin time. However, not everyone can receive glucocorticoids. So contraindications would include uncontrolled infections or sepsis, acute kidney injury, hepatorenal syndrome, uncontrolled upper GI bleeding, and active tuberculosis and multi-organ failure or shock. So that's the end of our discussion on alcohol-related liver disease. So let's now go to the next topic, which is non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease, or NAFLD, is a condition in which more than 5% of hepatocytes display macrovesicular steatosis in the absence of a readily identified alternative cause of steatosis. NAFLD is the most common cause of chronic liver disease in the United States as well as worldwide, and it is strongly associated with insulin resistance, overweight or obesity, and metabolic syndrome. For this reason, there has been a recent change in the nomenclature of this condition. Now it is called metabolic dysfunction associated steatotic liver disease, or MASLD. But since we are still using the 21st edition of Harrison's, so for this year we will stick with the term NAFLD. The spectrum of disease includes non-alcoholic fatty liver or steatosis or simple fatty liver. So shown here are fatty hepatocytes. This is the most clinically benign of the spectrum. Next, we have the non-alcoholic steatohepatitis, which is characterized by the presence of inflammation and cellular injury with or without fibrosis. And finally, cirrhosis, which is characterized by bands of fibrous septa leading to formation of cirrhotic nodules. The different spectrum have different clinical prognosis, with, of course, cirrhosis having the worst prognosis as it can lead to a lot of complications and even hepatocellular carcinoma. Fibrosis and the presence of steatohepatitis are the primary predictors of disease progression. Among patients with cirrhosis, progression to clinical decompensation ranges from 3% to 20% every year. The pathogenesis of NAFLD is not entirely clear, but basically when triglyceride synthesis overwhelm triglyceride disposal, then there will be accumulation of triglycerides or fats in the hepatocytes. Insulin resistance is the central factor or initiating event in NAFLD. This is the reason why patients who are obese, those who are diabetic, those who have metabolic syndrome or dyslipidemia are at most risk for NAFLD. The insulin resistance leads to increased lipolysis in adipose tissue, leading to elevated free fatty acid delivery to the liver. So you now have triglyceride accumulation and deposition in the liver or steatosis. Free fatty acids then undergo beta oxidation and peroxidation, generating reactive oxygen species, causing mitochondrial dysfunction, oxidative damage to the hepatocyte membranes, and endoplasmic reticulum stress. The damaged hepatocytes then activate Kupffer cells with release of inflammatory mediators that can lead to non-alcoholic steatohepatitis. Diagnosing NAFLD requires demonstration of increased liver fat in the absence of other factors like significant alcohol consumption. This can be done by imaging, with ultrasound being the first line. So on ultrasound, there is increased echogenicity, or what you call the bright liver, which suggests fat deposition. CT and MRI can also detect fatty liver, but these would be costly if you are just trying to check for fatty liver. In fatty liver or in NAFLD, the ALT is usually higher than the AST, unlike in alcohol-related liver disease. As a gastroenterologist, I usually get referrals from other services because of either fatty liver seen on ultrasound or other imaging, or because of elevated levels of ALT. So other tests for liver function are bilirubins, albumin, prothrombin time, GGT, and alkaline phosphatase. All these tests, however, may be completely normal, especially in simple fatty liver. So even the ALT and the AST may be normal during this time. Because there's no specific blood test for NAFLD, the confidence in the diagnosis of NAFLD is increased by identification of NAFLD risk factors. So this includes increase in body mass index, insulin resistance or the presence of type 2 diabetes mellitus, and other parameters that is indicative of metabolic syndrome. If we suspect other liver conditions, it is best to do further workup. So although these conditions are rare, especially here in the Philippines, no? So you should always check for the presence of chronic hepatitis. Sometimes you also have to check autoimmune markers as well as iron studies, alpha-1 antitrypsin, and ceruloplasmin. For staging of NAFLD, or assessing the severity or checking for fibrosis or cirrhosis, we have invasive and non-invasive tests. If we are going to be strict about it, biopsy is still the reference standard, but it is rarely done nowadays. It has risks, it is expensive, and most of all, there are now non-invasive options. By physical examination, we will have an idea if the patient has advanced disease, if there are signs of portal hypertension such as splenomegaly, ascites, encephalopathy, and so on. We combine this with laboratory tests to check for evidence of hepatic dysfunction or portal hypertension, but these are more applicable for patients who already have advanced liver disease, particularly cirrhosis. Equally important is how to check for fibrosis because it is at this stage that we can still reverse the condition. The NAFLD fibrosis score and the FIB-4 score are two of the most commonly employed non-invasive tests to assess severity of hepatic fibrosis, and these can be calculated from a few readily available clinical variables. So for NAFLD fibrosis score, you have age, BMI, glucose, platelet count, albumin, AST, and ALT. And for FIB-4 score, it is more simple. You just have the age, ALT, AST, and the platelet count. So you can use this, and calculators are actually available to calculate for the scores. And both are helpful for checking the severity of NASH and liver fibrosis. We can combine this with new imaging modalities that permit non-invasive quantification of liver fat and liver stiffness, such as MRI using proton density fat fraction, MR elastography, and transient elastography. Patients with NAFLD are often asymptomatic. Sometimes they would feel vague right upper quadrant pain, but most of the time, the diagnosis of NAFLD is made due to incidental findings of fatty liver on ultrasound or maybe an elevated ALT. Since most patients with NAFLD are metabolic dysfunction associated, there can be signs of metabolic syndrome. Some would also have subtle stigmata of chronic liver disease such as spider angioma or palmar erythema. And in some, the presentation would be complications of decompensated cirrhosis such as vomiting of fresh blood due to esophageal varices. There are no specific therapy for the treatment of NAFLD. You may have heard about phospholipids, silymarin, etc., but these are just actually supplements. What we often do is we identify the metabolic factors associated with NAFLD. So we check for obesity, insulin resistance, metabolic syndrome, dyslipidemia, and these are the ones that we treat. And of course, we treat the complications of advanced NAFLD, and this one we will discuss later. The most important part of treatment is lifestyle modification. Dietary modifications and regular exercise are very important. So the goal is to lose weight. A weight loss of 3 to 5% of body weight improves steatosis, and an even bigger weight loss of 7% to 10% improves steatohepatitis and hepatic fibrosis. Now, a number of medical or pharmacologic therapies to facilitate weight loss, such as orlistat, topiramate, GLP-1 receptor agonists are available, but for now, their role in the treatment of NAFLD remains experimental. As for the diet with high calories should be avoided. So these include saturated fats, refined carbohydrates, and sugar-sweetened beverages. People modify their diet in different ways. So some would go on low-carb diet, some would go on intermittent fasting, and they all appear comparable in their ability to improve NAFLD. So they say that the best diet is actually the one that you can sustain. Although there's one particular type of diet, the Mediterranean diet, that is often recommended to patients with NAFLD, and this is based on its associated improvement in cardiovascular health and reduction in liver fat. So this diet consists of high intake of fruits and vegetables, high intake of monounsaturated fats like extra virgin olive oil, moderate intake of fish and poultry, low intake of red or processed meats, and minimal ultra-processed food. Excessive fructose consumption should also be avoided independent of calorie intake. And for the last, a lot of people will be interested in this. So coffee consumption independent of caffeine content may also be beneficial. So Drinking 2 or more cups of coffee per day could be recommended in the absence of contraindications based on the reduced risk for NAFLD and liver fibrosis demonstrated in epidemiological studies and meta-analysis. Exercise independent of weight loss has hepatic benefit because it improves muscle insulin sensitivity, which improves the metabolic syndrome. The intensity and duration should be individualized, but some studies demonstrate that 30 minutes of moderate intensity aerobic exercise or resistance training at least 5 times per week for a total of 150 minutes per week can prevent or improve NAFLD. Again, there are currently no FDA-approved drugs for the treatment of NAFLD. So at present, NAFLD patients without NASH or fibrosis should receive only counseling for healthy diet and physical activity, and consideration of additional specific pharmacotherapy for liver disease is restricted to patients with NAFLD who have more serious damage, such as those with NASH and liver fibrosis. The first option is pioglitazone. So these drugs increase insulin sensitivity in the muscle, in the liver, and in the adipose tissue. So they decrease hepatic fat accumulation. Pioglitazone has the strongest evidence among current pharmacologic options for histologic improvement. So this can be used in patients with NASH, especially those with type 2 diabetes or prediabetes. Although there are reports of adverse events such as weight gain, heart failure, the risk for bladder cancer, and bone fractures in women. The next is vitamin E. So vitamin E is a potent antioxidant, and we know that oxidative stress is thought to contribute to the pathogenesis of NASH. So along with pioglitazone, these are the most studied meds for NAFLD. It is important to note that studies involving the use of vitamin E, although they had favorable outcome like improvement in histology, they were actually used for biopsy-proven NASH in those studies. And we usually do not biopsy we do not usually do biopsy in patients with NAFLD, as discussed a while ago. Long-term vitamin E intake is not without risk. Chronic vitamin E therapy may increase the risk of cardiovascular mortality, hemorrhagic stroke, and prostate cancer. And so, vitamin E should only be considered as a first-line pharmacotherapy for non-diabetic, non-cirrhotic NASH who are at low risk for cardiovascular disease or prostate cancer. Two other drugs that are both approved for DM and can both promote weight loss are being studied for their effect on NASH. Incretin mimetics act on the pancreas to optimize insulin secretion, while SGL2 inhibitors promote urinary glucose excretion. Again, they are both approved for the treatment of diabetes mellitus. However, they are currently not approved specifically for the treatment of NASH. These are the other drugs that have been studied but have no proven benefits. So these include ursodeoxycholic acid, betaine, omega-3 fatty acids, and statins. The aim of bariatric surgery is to treat obesity, and since obesity and insulin resistance are major risk factors for NAFLD, it is expected that bariatric surgery can have a positive effect in NAFLD. Not all individuals can undergo bariatric surgery. So currently, the criteria for bariatric surgery are a BMI of at least 40, irrespective of metabolic comorbid disease, or a BMI of at least 35 if with comorbidities. Most studies of bariatric surgery have shown that bariatric surgery is generally safe in individuals with well-compensated chronic liver disease, and it improves hepatic steatosis and necroinflammation. But the effects on hepatic fibrosis have been variable. So while NAFLD or NASH alone is not an indication for bariatric surgery, it is not a contraindication and may even be of benefit in improving hepatic steatosis and necroinflammation. However, those who have advanced disease like NAFLD-related cirrhosis, especially those who have portal hypertension, should not undergo bariatric surgery. Let's now go to the last topic for today and probably the most exciting. So this is cirrhosis and its complications. If you will search for the definition of cirrhosis, one term that will always be there is scarring or fibrosis. So cirrhosis is a chronic condition of the liver in which the normal functioning tissue or parenchyma is replaced with scar tissue or fibrosis and regenerative nodules. It was previously believed that cirrhosis is irreversible, but now there is evidence that when the cirrhosis is detected early or when it is still compensated, by compensated I mean no signs of advanced disease or complication, and then the cause is removed, then there can be reversal of fibrosis. So one example is when you treat hepatitis B or hepatitis C in a patient with beginning cirrhosis or compensated cirrhosis. Regardless of the cause, cirrhosis will still have the same clinical features. So in the early stages, when there are no complications yet, the disease may be clinically silent, although there may be some non-specific symptoms such as fatigue and generalized weakness. There may be right upper quadrant discomfort, nausea, vomiting, poor appetite, and weight loss. So these symptoms may precede obvious signs of liver disease. Patients with cirrhosis can also present with more specific signs of chronic liver disease, which may be due to hepatocyte injuries such as ictericia, parotid gland enlargement, gynecomastia. You have spider angioma, digital clubbing, palmar erythema, or bipedal edema. But they can also present with a complication as their initial symptom, and these are usually due to effects of portal hypertension. So examples are upper GI bleeding or hematemesis due to esophageal varices. They can also present with ascites or encephalopathy. And there are even times when patients who are not even known to have cirrhosis would have a sudden onset of a symptom of decompensation, like sudden vomiting of fresh blood, which may be indicative of GI bleeding from esophageal varices, and that would be the only time that a workup would be done, which might reveal decompensated cirrhosis. These are the causes of cirrhosis, but I will only be discussing the more common ones. We'll discuss first alcohol-associated cirrhosis. This represents the final stage of the spectrum of alcohol-related liver diseases. So the nodules in alcohol-related cirrhosis are usually less than 3 millimeters in diameter. So this form of cirrhosis is micronodular cirrhosis. But then with cessation of alcohol use, larger nodules may form, resulting in a mixed micronodular and macronodular cirrhosis. This is the pathogenesis of alcohol-associated cirrhosis. I already discussed this a while ago. Just an additional information that this process takes years to decades to occur, and it requires repeated insults. So the transition from simple alcoholic steatosis to cirrhosis does not simply happen overnight. There are a lot of symptoms of cirrhosis, and the clinical features are similar regardless of the cause. But I will just mention these symptoms under alcohol-associated cirrhosis because they are much more common and much more pronounced in alcohol-associated cirrhosis than in cirrhosis due to other causes. And this is due to toxic effects of alcohol on the testes, causing hypogonadism and subsequent decrease in testosterone and increase in estrogen. Women with alcohol-associated cirrhosis also have menstrual cycle irregularities because chronic alcohol use directly impairs ovarian function and disrupts pituitary release of luteinizing hormone and follicle-stimulating hormone. And patients with alcohol-associated cirrhosis are more prone to Dupuytren's contracture. So, alcohol causes microvascular injury to the palmar fascia because acetaldehyde and oxidative stress activate fibroblasts, which cause excess collagen. So, the result is a thickened palmar fascia with nodules, and it leads to a fixed flexion deformity known as Dupuytren's contracture. Anemia may be seen in patients with alcohol-associated cirrhosis, and this may be due to chronic gastrointestinal blood loss, nutritional deficiencies, or hypersplenism, or as a direct suppressive effect of alcohol on the bone marrow. A unique form of hemolytic anemia called the Sieve syndrome can occur in patients with severe alcoholic hepatitis. This is a transient metabolic and hematologic complication of alcohol-induced liver injury with a triad of hemolytic anemia, hyperlipidemia, and jaundice. Platelet counts are often reduced early in the disease, and this is reflective of portal hypertension with hypersplenism. Prothrombin time is often prolonged and do not usually respond to administration of parenteral vitamin K. And the AST and ALT are usually elevated with a 2:1 ratio. For the diagnosis of alcohol-related cirrhosis, of course, we should check if the alcohol intake is sufficient or significant enough to cause cirrhosis. We should always rule out other causes of chronic liver disease. Liver biopsy is not usually performed, but if the diagnosis is unclear or you are thinking of other possible causes, then it might be helpful. For the treatment, abstinence is the cornerstone of therapy for patients with alcohol-associated liver disease. So even if you give whatever treatment, for as long as the patient continues to drink alcohol, then there will be progression of the condition. Good nutrition is also important, and we should also educate the patients for possible complications, what to watch out for, like the development of ascites, variceal hemorrhage, encephalopathy, and if these are present, this all requires specific management, which I will discuss later. And lastly, liver transplantation can be an effective long-term treatment, but these should only be an option for those who are low risk for alcohol relapse and those who do not respond to other treatments. Let's now go to cirrhosis due to chronic viral hepatitis. In developed countries, alcohol and NAFLD are now the leading causes of cirrhosis. So there has been an overall shift from viral causes to metabolic and lifestyle-related causes. But in developing countries like the Philippines, viral hepatitis is still dominant. So cirrhosis due to chronic viral hepatitis have a mixed type of micro and macronodular cirrhosis. Here in the Philippines, hepatitis B is the more common form. In fact, this is one of the most common causes of chronic liver disease here. Hepatitis C is very rare in the Philippines. So of adult patients exposed to hepatitis B, around 5% develop chronic hepatitis B, and 20% of those will go on to develop cirrhosis. 5%, that's a very small number, right? But that's just for those who were exposed during adulthood, meaning only those who were exposed by exchange of body fluids like sexual intercourse or bloodborne. But the primary mode of chronic hepatitis B is actually perinatal. They are acquired from the mother during childbirth, and with this route, 95% will actually carry it into adulthood, so they become chronic hepatitis B. And approximately 25% of these individuals may ultimately develop cirrhosis. For chronic hepatitis C, of patients exposed to chronic hep C virus, 80% develop chronic hepatitis C, and of those, around 20 to 30% will develop cirrhosis. So, hepatitis C causes slow progressive fibrosis, and this develops over decades. So, the cirrhosis is usually seen after 20 to 30 years. And the mode of transmission is usually bloodborne. So, fortunately, hep C is rare. Since we are talking about individuals here who already have cirrhosis, what we want to do is to prevent complications. We treat the virus because we want to suppress their activity. So for hepatitis B, we have a number of options for those already with cirrhosis. We usually give this lifetime. For hepatitis C, the management used to be very difficult some years back because pegylated interferon plus ribavirin used to be the only form of treatment. It was expensive with a lot of side effects and was only through IV form. So patient compliance was really not that good. Plus, it cannot be given to those with cirrhosis due to side effects. Now, we have direct-acting antivirals in tablet form. They are very effective, a bit expensive, yes, but you only have to give it for 8 to 12 weeks. So these are just some of the options, and the available form here is sofosbuvir plus velpatasvir. Aside from targeting the cause, we also try to prevent complications like esophageal varices or development of ascites and edema or encephalopathy. And if present, we again try to manage these complications. Autoimmune hepatitis is not really one of the first things that you will consider as a cause of cirrhosis. So this diagnosis is usually delayed. Workup for autoimmune hepatitis would be if you already excluded other possible causes. Diagnosis in this setting requires a positive ANA or anti-smooth muscle antibody. It is usually reversible if detected early and for those with signs of active inflammation like elevated liver enzymes. The treatment of choice is immunosuppressive therapy using either azathioprine or steroids. But for those with established cirrhosis, these patients will not benefit from immunosuppressive therapy, and all you can do is to prevent, delay, or manage the complications. Cirrhosis due to NAFLD was discussed a while ago. So this is the fastest growing cause of cirrhosis nationwide, and this is expected to become the leading cause of liver transplantation in many countries. So again, it is strongly linked to obesity, diabetes, and metabolic syndrome. Biliary cirrhosis refers to cirrhosis which is caused by chronic injury to the bile duct. This may be due to inflammatory lesions, congenital or metabolic processes, or external bile duct compression. As a result, there can be cholestasis or impaired bile flow, and later on, inflammation, fibrosis, and eventually cirrhosis. Despite the difference in pathogenesis with other causes of cirrhosis, the manifestations of end-stage liver disease are the same. So there are two major causes, the primary biliary cirrhosis and the primary sclerosing cholangitis. They share the same histopathologic features of chronic cholestasis, such as cholestasis, copper deposition, xanthomatous transformation of hepatocytes, and irregular so-called biliary fibrosis. In addition, there may be chronic portal inflammation, interface activity, and chronic lobular inflammation. Primary biliary cirrhosis, or PBC, is a very rare disorder, and most of these patients are middle-aged women with the median age being 50 at the time of diagnosis. The cause of PBC is unknown, although it is believed to be caused by autoimmune attack in small and medium-sized bile ducts, causing portal inflammation and necrosis of cholangiocytes. Patients may be asymptomatic early on, or they may present with fatigue or pruritus, which may easily be mistaken for some other conditions. But as the disease progresses, there may be signs of chronic liver disease like hepatomegaly, splenomegaly, ascites, and edema. Some features that are unique to PBC include hyperpigmentation, usually in the arms and trunk, xanthelasma, and xanthomata, which are yellowish cholesterol deposits under the skin, all of which are related to altered cholesterol metabolism. Laboratory findings in PBC would show elevation in GGT and alkaline phosphatase, and only mild elevation in ALT and AST. So this elevation in ALK-PHOS plus mild elevation in ALT-AST signify cholestatic liver disease. Immunoglobulins, particularly IgM, are typically increased, and anti-mitochondrial antibodies, or AMAs, are present in 95% of patients with PBC. So that leaves around just 5% of patients who may have a negative AMA but actually have PBC. And this is where liver biopsy would be most helpful. If there's already portal hypertension and hypersplenism, we can also see thrombocytopenia, leukopenia, and anemia. The first line and standard of treatment is ursodeoxycholic acid. This is a readily available drug, sometimes used as a hepatic protectant or for gallstone dissolution. So, ursodeoxycholic acid, or UDCA, improves bile flow, reduces cholestatic injury and inflammation, and slows down the progression of fibrosis, but it cannot reverse or cure the disease. So this should be started early, because if there's cirrhosis already, the improvement with ursodeoxycholic acid is very low. The second line, if there is no significant improvement with UDCA, is obeticholic acid. Then we do supportive treatment. For pruritus, the first line is cholestyramine. Although antihistamines are often tried, and naltrexone and rifampin can also be used. Patients with long-term cholestasis can also have osteoporosis, so you might want to start calcium supplement, vitamin D, and bisphosphonate. The other type of biliary cirrhosis is primary sclerosing cholangitis, or PSC. The cause of PSC is unknown. PSC is characterized by diffuse inflammation and fibrosis involving the entire biliary tree, resulting in chronic cholestasis. This leads to bile duct strictures, biliary obstruction, cholestasis, and ultimately biliary cirrhosis, along with its complications, and liver failure. So the chronic inflammation and fibrosis in PSC leads to the beading appearance of bile ducts due to alternating strictures and dilatations. The symptoms are typical of cholestatic liver disease. So fatigue and pruritus are the most prominent, and all of these can also be seen in primary biliary cirrhosis. So same as primary biliary cirrhosis, patients can also be asymptomatic early on. Patients with PSC typically are identified during an evaluation of abnormal liver enzymes. Typical of a cholestatic liver disease, there is an increase in alkaline phosphatase with mild elevations in ALT and AST. A small percentage of patients can have an overlap syndrome with autoimmune hepatitis, and in these cases, the ALT levels may be highly elevated. And then there's one autoantibody, the perinuclear anti-neutrophil cytoplasmic antibody or PANCA, that is positive in 65% of patients with PSC. Also, around 60 to 80% of patients with PSC have inflammatory bowel disease, predominantly ulcerative colitis, so a colonoscopy is also recommended at diagnosis. In PSC, there are stricturing in the intrahepatic and extrahepatic biliary tree. So this causes obstruction and dilatation of the proximal segments, so it will look like a beaded appearance. On MRCP, you will appreciate these strictures and dilatations, and you can also appreciate this on ERCP, although ERCP is now reserved for therapeutic purposes like dilation or stent insertion in those with dominant strictures. There's no specific treatment that is proven for PSC, although some clinicians use ursodeoxycholic acid similar to PBC. But there are no studies that have shown convincing evidence of clinical benefit. Episodes of cholangitis should be treated with antibiotics, and ERCP can be done to dilate dominant strictures, but the ultimate treatment is still liver transplantation when decompensated cirrhosis develops. Patients with long-standing right-sided congestive heart failure may develop chronic liver injury and cardiac cirrhosis. So when there is right-sided heart failure, central venous pressure increases, and this backs up into the hepatic veins, causing chronic passive congestion, and then leading to hepatocyte necrosis and fibrosis around the central veins, and then eventually cirrhosis. The most prominent symptoms are signs of congestive heart failure with maybe an elevation of alkaline phosphatase and mild elevations in AST and ALT. These are some of the less common causes of chronic liver disease that can progress to cirrhosis, but we will not discuss them during this lecture. We now go to the major complications of cirrhosis, and we will focus on the more important complications. Portal hypertension is defined as the elevation of the hepatic venous pressure gradient to at least 5 millimeters mercury. During this time, patients are still asymptomatic with no complications. So this is what happens in compensated cirrhosis. But when clinically significant portal hypertension develops, this is defined as having an HVPG of at least 10 millimeters mercury. Then there is high risk of decompensation, which could include variceal bleeding, ascites, or hepatic encephalopathy. The two hemodynamic processes that are involved in portal hypertension are increased intrahepatic resistance to the passage of blood flow through the liver due to cirrhosis, regenerative nodules, or microthrombi, and increased splanchnic blood flow secondary to vasodilation within the splanchnic vascular bed. So this is what happens in portal hypertension. There is an increase in resistance to portal flow, which accounts for most of the rise in portal pressure. The cirrhosis distorts the liver architecture because of the fibrosis, the regenerative nodules, and the vascular remodeling compressing on the sinusoids. So this creates a mechanical obstruction to portal flow. So what happens is portal blood cannot easily pass through the liver and pressure builds up in the portal system. Then you also have vasodilation within the splanchnic vascular bed, and this is due to excess nitric oxide and other vasodilators. This leads to increased blood flow to the portal vein, adding more volume to an already high pressure system. And because of this dilation, there will be a decrease in the effective circulating volume, which would then trigger the renin-angiotensin-aldosterone system to retain salt and water, and this will increase the cardiac output and will cause more inflow into the portal system. There are a number of possible causes of portal hypertension. It can be prehepatic, which means the conditions affect the portal venous system before it enters the liver. Examples are portal vein thrombosis and splenic vein thrombosis. Etiology can also be posthepatic, which includes conditions affecting the hepatic veins and the venous drainage to the heart. So examples are Budd-Chiari system and chronic right-sided cardiac congestion. But majority are intrahepatic causes, accounting for more than 95% of cases of portal hypertension. And these are represented by the major forms of cirrhosis. Intrahepatic causes of portal hypertension can further be subdivided into pre-sinusoidal, sinusoidal, and post-sinusoidal causes. So the major pre-sinusoidal causes are schistosomiasis and primary biliary cirrhosis. For post-sinusoidal causes, we have veno-occlusive disease. And for sinusoidal causes, these are related to cirrhosis from various causes. Esophageal varices are dilated submucosal veins in the lower esophagus that develop because of portal hypertension. When portal pressure rises, the body compensates by forming alternative venous channels that connect the portal and systemic circulation, and one of the most prominent in cirrhotics are esophageal varices. These collaterals somehow help decompress the portal system, but they cause major clinical consequences, and the most important is gastrointestinal bleeding. So for diagnosis, we perform upper GI endoscopy, and these are the esophageal varices as seen on endoscopy. So the question now is, for patients with cirrhosis, when is endoscopy with screening for varices recommended? And by screening, I mean those patients with no history of bleeding. The value of screening is it will identify those who have varices and those who are at risk for bleeding and may need medications or prophylaxis. So endoscopy for screening are recommended at diagnosis of compensated cirrhosis, especially for those with thrombocytopenia and splenomegaly, and then every 2 years if the liver disease is active. If the disease is inactive, like for example for those who have alcohol-related cirrhosis but who stop drinking alcohol, or for those viral hepatitis who have been treated, we do surveillance every 3 years. And then endoscopy is also recommended at the time of hepatic decompensation, like for a known compensated cirrhotic who suddenly develops gastrointestinal bleeding or encephalopathy or ascites. Gastrointestinal bleeding from esophageal varices is a life-threatening problem because the bleeding is usually massive and the mortality rate is high at around 20 to 30% with each episode of bleeding. It is said that around one-third of patients with varices will eventually bleed. And these are the risk factors for bleeding. One is the severity of cirrhosis. So the higher the MELD score and the Child-Pugh score, the higher the risk of bleeding. Next is a hepatic venous pressure gradient of at least 12. So the higher the portal pressure, again, the greater the risk of bleeding. Next, we have the size of the varix, with those varices at least 5 millimeters being at risk for gastrointestinal bleeding. Next is the location of the varix. The most common and the most dangerous site of bleeding from esophageal varices is the distal 2 to 3 centimeters of the esophagus, particularly the gastroesophageal junction, because this is where the portal venous system via the left gastric or the coronary vein connects with the systemic venous system via the azygos vein. Next is endoscopic findings of recent or active bleeding. So we have stigmata of bleeding. We have the red whale signs. We can also appreciate other signs of high risk for bleeding, which are hematocystic spots, diffuse erythema, cherry red spots, or white nipple spots. And then lastly, tense ascites or anything that will increase the intra-abdominal pressure is high risk for gastrointestinal bleeding due to esophageal varices. For primary prophylaxis, so these are for cases who have no history of bleeding but are at risk. Medications using non-selective beta blockers can be started. It is believed to be as effective as endoscopic variceal ligation, and the goal is to have a heart rate of around 55 to 60 beats per minute. So the beta blockers slow down the heart rate, decrease the portal pressure, but it is also an antihypertensive, so the systolic BP should not be below 90 millimeters mercury. It can also cause bronchospasm, so patients with asthma or COPD may not be able to tolerate this. So for those in whom non-selective beta blockers cannot be given, then endoscopic variceal ligation should be performed. We also call this rubber band ligation. So during endoscopy, the varix, usually the distalmost or the one with the red whale sign, is suctioned into a transparent cap at the tip of the endoscope. A rubber band is released around the base of the sucked varix, and this band cuts off the blood flow to the varix. It then thromboses and necroses, and then later on it will slough off and eventually will have fibrosis, and that's the goal. We then repeat this process every 2 to 4 weeks until all the varices are obliterated. During acute variceal bleeding, the bleeding is usually massive since the blood source are blood vessels. So usually the patient will present with sudden onset of vomiting of fresh blood. So if a patient comes to you with vomiting of fresh blood and with no other symptoms, you check for clues. Check for signs of chronic liver disease on physical examination and work the patient up for possible chronic liver disease. For these patients, of course, we stabilize the patient first. We expect anemia, but we don't aggressively transfuse. Instead, we transfuse only if the hemoglobin level is below 7 grams per deciliter. So the goal is to have a hemoglobin of around 7 to 9 grams per deciliter. And this is for patients with no cardiac problems. But for patients with cardiac risk, the hemoglobin goal may be higher. Another usual finding in patients with decompensated cirrhosis is that their prothrombin time are often deranged. The prothrombin time is a bleeding parameter, but in cirrhotic patients, the derangement in prothrombin time actually reflects poor synthetic function of the liver and does not necessarily mean an increased bleeding tendency. Correcting an elevated prothrombin time with fresh frozen plasma is not recommended unless there is evidence of coagulopathy. Next is the use of vasoconstricting agents. So usually we use somatostatin or octreotide to improve the initial bleeding control and reduce the transfusion requirements and all-cause mortality. And we also give prophylactic antibiotics, usually ceftriaxone, prior to endoscopy. And this has been proven to reduce infections, recurrent bleeding, and mortality. And then, of course, we prepare for endoscopy and possible definitive treatment using endoscopic variceal ligation. If available, an option of placing a balloon tamponade can be used to control the severe bleeding from esophageal varices. This is done by mechanically compressing the bleeding veins using an inflated balloon, but this is just a temporary measure while preparing for endoscopy with endoscopic variceal ligation. Aside from esophageal varices, there can also be gastric varices. So gastric varices may be in continuity with esophageal varices, or they may occur distal from the esophageal varices. So for these individuals, endoscopic variceal ligation will most likely be unsuccessful, and the treatment of choice would be cyanoacrylate injection. This is like an instant glue that hardens when it comes in contact with blood. So you inject them on the gastric varices, and then it will form a solid plug that would block blood flow through the varix. And not a lot of hospitals allow their doctors or gastroenterologists to do this procedure because it can actually cause damage to the endoscope. Anyway, going back to esophageal varices, so whether or not you use balloon tamponade, no, so you should be preparing for endoscopic variceal ligation, which I showed you a while ago. And for those whose bleeding cannot be controlled even with endoscopic variceal ligation, again, you can consider placing a tube to tamponade while waiting for your next intervention, which would probably be TIPS. TIPS stand for transjugular intrahepatic portosystemic shunt. So this is the creation of a shunt or a bridge within the liver to connect the portal vein, which carries blood from the intestines to the liver, to a hepatic vein which drains blood from the liver to the heart. So this is the shunt. And this allows blood to flow more easily through the liver and bypass the portal hypertension. So this procedure is done by interventional radiologists. Hepatic encephalopathy can occur in 20% of patients who undergo TIPS. This is because the blood bypasses liver detoxification, leading to a buildup of ammonia and toxins, and this would create confusion and disorientation. TIPS can reduce high pressure in the portal venous system and prevent its complications, but of course this is not this does not solve everything. So this is more of a bridge to a liver transplant. The next complication related to portal hypertension is portal hypertensive gastropathy. When esophageal varices are already present, then most likely there is also portal hypertensive gastropathy. So this is characterized by endoscopic findings showing snake snakeskin-like mosaic pattern of gastric mucosa that often comes with central red or brown spots. So it can cause both acute clinical gastrointestinal bleeding and chronic bleeding resulting in iron deficiency anemia. When there is bleeding, the treatment is uh, non-selective beta blockers and iron supplements. Usually, the first clue that portal hypertension has developed is having splenomegaly or hypersplenism. So, if you have a patient with a recently diagnosed cirrhosis and you want to have a clue if there is already portal hypertension, then you check the spleen. So, splenomegaly is the enlargement of the spleen. So, this is more of a structural change, while hypersplenism is a functional overactivity leading to low blood cell counts. So, this is functional. Clinical features include the presence of an enlarged spleen on physical examination and the development of thrombocytopenia and leukopenia in patients who have cirrhosis. Some patients will have significant left-sided or left upper quadrant abdominal pain related to an enlarged spleen, but most will have no symptoms at all. Ascites is the accumulation of fluid within the peritoneal cavity. Symptoms include an increase in abdominal girth, often accompanied by peripheral edema. Usually, there's no pain unless there is infection or spontaneous bacterial peritonitis, which I will discuss later. And on physical examination, there will be bulging flanks, fluid wave, and shifting dullness. The most common cause of ascites is portal hypertension. In cirrhosis with portal hypertension, there is increased lymphatic flow from the liver leading to the formation of ascites. But more importantly, when there is vasodilation of the splanchnic arterial system, this leads to arterial vasodilation and underfilling in the intestines and abdominal organs. So the total volume of blood increases, but effective arterial blood volume actually drops. But because the kidneys will think of this as having a low blood volume, there is activation of the renin-angiotensin-aldosterone system, which eventually leads to sodium retention and water retention. Again, portal hypertension is the most common cause of ascites. So if the patient is a known cirrhotic, then most likely there is already portal hypertension. There are times though that a patient has no known liver disease and ascites is the first manifestation. So in these cases, other causes of ascites should also be ruled out. So you rule out malignant, infectious, and cardiac causes. And also, since patients with cirrhosis has a high risk for hepatocellular carcinoma, all patients with cirrhosis who developed ascites should also be worked up. Patients suspected of having ascites based on history and physical examination should undergo imaging to confirm the presence of ascites and to look for evidence of cirrhosis or malignancy. And the most cost-effective modality is ultrasound. So ultrasound can confirm the presence of ascites. It can examine the liver for cirrhosis or masses without the risk of radiation. But if there is a need for more detailed examination, then CT scan would be another option. So when patients present with ascites for the first time, it is recommended that a diagnostic paracentesis be performed to characterize the fluid. This is a bedside procedure, usually guided by ultrasound in order to get samples of the ascitic fluid. So for diagnostic paracentesis, just a few ml of fluid is taken and the specimen should be sent to the laboratory for determination of total protein and albumin content, blood cell counts with differentials, cultures, cell cytology to check for malignancy. And here in the Philippines, We also request for tuberculosis test. So we check for tuberculosis using TB-PCR of the acidic fluid. In patients with cirrhosis, the characteristic is that the protein concentration of the acidic fluid is low. Usually, it is less than 2.5 grams per deciliter. Aside from this, we can also check for the serum albumin, serum ascites to albumin gradient, or SAAG. This is very important because a SAAG of more than 1.1 gram per deciliter is indicative of portal hypertension being the cause of the ascites, and a SAAG of less than 1.1 would essentially rule out cirrhosis as the cause of ascites. Portal hypertension is the most common cause of ascites, but not all patients with ascites are caused by portal hypertension. So we use the acidic fluid analysis to determine the cause of ascites, and the SAAG is also very important in determining the cause. So the SAAG is calculated by subtracting the fluid albumin level from the serum albumin level. When the SAAG is more than 1.1 gram per deciliter, and the acidic fluid or total protein is low at less than 2.5 grams per deciliter, then most likely the cause is portal hypertension, and the most common cause of portal hypertension is cirrhosis. Although this picture of acidic fluid can also be caused by massive liver metastasis. Cardiac cirrhosis also has a SAAG of more than 1.1, but the acidic fluid protein is more than 2.5 as compared to that of cirrhosis, which has a low total protein. When the SAAG is less than 1.1, then you consider infectious or malignant causes of ascites. The first step in the management of ascites is sodium restriction. So the recommendation is to limit sodium intake to less than 2 grams per day. So this is equivalent to slightly more than 3/4 of a teaspoon of salt. They say that most average diets in the United States contain around 6 to 8 grams of sodium per day, and if a patient eats in restaurants or fast food outlets, then the amount of sodium in their diet can already exceed the recommended daily intake. So the problem here actually is how patients can be able to adhere to this recommendation. And often, a simple recommendation is to eat fresh or frozen food, avoid canned food or processed food, or here in the Philippines, no added salt to the food. Fluid restriction is not needed and is not part of the management of ascites because ascites caused by cirrhosis is due to sodium retention and not water overload. So for patients with mild ascites, sodium restriction would be the only management that is needed. For moderate ascites, diuretics are usually needed. The first-line diuretic for ascites is spironolactone. This is an aldosterone receptor antagonist. Spironolactone is the first line because aldosterone levels are high in cirrhosis. So this helps increase the excretion of salt and water while retaining potassium. So this cannot be given to patients with hyperkalemia. The recommendation is to start spironolactone at 100 milligrams per day, and furosemide may also be added at 40 milligrams per day, particularly in patients who have peripheral edema. This 100 milligrams spironolactone to 40 milligram furosemide ratio is adjusted every 3 to 5 days if needed to keep the potassium balance stable. The target weight loss during diuresis is 0.5 kilograms per day if the patient has no edema, and 1 kilogram per day in patients with edema. If ascites does not resolve despite a low sodium diet and diuretics, or quickly recurs after paracentesis, then that would be refractory ascites. So treatment options would then include repeated large volume paracentesis or a consideration for TIPS. Large volume paracentesis is taking at least 5 liters of acidic fluid by paracentesis. But if this is to be done, intravenous albumin should be given during paracentesis to prevent circulatory dysfunction. How much albumin should we infuse? We infuse 8 grams of albumin for every liter of acidic fluid that is removed after the first 5 liters. So for example, if a total of 8 liters acidic fluid is removed, so that would be 3 liters beyond the first 5. So we give 24 grams of albumin because 3 liters beyond the first times 8 grams of albumin for every liter, so you have 24 grams of albumin. Being a volume expander, albumin counteracts the sudden drop in effective arterial blood volume after fluid drainage. Then the next option is TIPS. Again, TIPS is done to reduce the portal hypertension and therefore decrease its effects like ascites. Again, the risk is encephalopathy. And since ascites is a sign of decompensation, there should be a consideration for liver transplantation. Another option actually, though not in Harrison's but is a common practice here, is placing a pigtail catheter and keeping it in place instead of just doing a large volume paracentesis. So with this option, the patient can drain the fluid at home every day and they will be taught to drain a certain amount of fluid every day, but the risk of course is infection on the site. Spontaneous bacterial peritonitis is a complication of ascites wherein the fluid is infected without an intra-abdominal cause such as abscess or perforation. When we use the term peritonitis, the treatment is almost always surgical, but in SBP, there is no surgically treatable intra-abdominal source. SBP occurs due to bacterial translocation from the gut into the mesenteric lymph nodes, then to the bloodstream, and then seeding into the ascitic fluid. The most common organisms are E. coli and other gut bacteria, although gram-positive bacteria including Streptococcus viridans, Staphylococcus aureus, and Enterococcus can also be found. When SBP is suspected, paracentesis should be performed. The diagnosis of SBP is made when the acidic fluid taken during the paracentesis has an absolute neutrophil count of more than 250 per microliter. Cultures should be obtained during paracentesis to guide in the management. And it is important to note that in SBP, only one organism is responsible. So if there are 2 or more organisms found in the culture, then you should suspect other causes of peritonitis. Patients with ascites or SBP may present with fever, altered mental status, elevated WBC count, abdominal pain or discomfort, acute kidney injury, but SBP can also have minimal symptoms or can be silent. It can be the trigger for encephalopathy or hepatorenal syndrome, so a high index of suspicion is important. SBP is usually treated with intravenous third-generation cephalosporin for 5 days. It is important to start antibiotics once you suspect SBP. Intravenous albumin at 1.5 grams per kilogram body weight on day 1 and 1 gram per kilogram body weight on day 3 is also given to reduce the risk of renal failure and It is also proven to improve survival. And for patients who recover from SBP, it is recommended that secondary prophylaxis, usually using quinolones, should be given to prevent recurrent SBP. Hepatorenal syndrome, or HRS, is a form of functional renal failure without renal pathology that occurs in 10% of patients with advanced cirrhosis or acute liver failure. It means that the patient has no prior kidney problems and the kidneys are structurally normal. HRS requires exclusion of other causes of acute renal failure, and most notably volume depletion. So, renal vasoconstriction is the most important mechanism and is mainly due to splanchnic vasodilation as seen in cirrhotics, and this leads to decrease in arterial blood volume and activation of RAAS. But if this is just a problem, then probably all patients with cirrhosis with portal hypertension will have HRS, right? Well, the pathogenesis is most likely multifactorial, but almost always there is a trigger. And the usual precipitating factors are spontaneous bacterial peritonitis, gastrointestinal bleeding, excessive diuretic use, or paracentesis without albumin, and severe infection or dehydration. We suspect HRS in patients with ascites and worsening kidney function, so there will be progressive increase in the creatinine and there may be oliguria. Type 1 HRS is characterized by a progressive impairment in renal function and a significant reduction in creatinine clearance within 1 to 2 weeks of presentation. And type 2 HRS is characterized by a reduction in glomerular filtration rate with an elevation of serum creatinine level, but it is stable and this is associated with a better outcome than that of type 1 HRS. Treatment is the same for both types of HRS. First, we treat the precipitating factors. If infection, like SBP or something else, then we give antibiotics. If there is gastrointestinal bleeding, we address the gastrointestinal bleeding. Also, hypovolemia is one common precipitating factor, so diuretics should be stopped at this point. Volume expansion using IV albumin is also recommended. This is, of course, to improve the intravascular volume. And treatment with vasoconstrictors like terlipressin is also recommended. And in many regions, terlipressin plus albumin is the first-line treatment. Norepinephrine is also a vasoconstrictor, which may be more readily available than terlipressin. So, starting low-dose norepinephrine via continuous IV infusion is an option as well. Although this would require intensive care unit monitoring since this can increase the blood pressure quickly. Midodrine and octreotide are also used in some areas, but the best therapy and only curative option for HRS would be liver transplantation. Another serious complication of cirrhosis is hepatic encephalopathy. This is defined as an alternation in mental status and cognitive function occurring in the presence of liver failure. Again, I use the term liver failure because in general, hepatic encephalopathy can also be seen in patients with acute liver failure. For example, those with no known liver disease such as drug-induced liver injury. But more often, it is seen in those with cirrhosis. What happens here is that the gut-derived neurotoxins are not removed by the liver because of vascular shunting and decreased hepatic mass. Instead, they bypass the liver, where they are supposed to be detoxified and they reach the brain. Despite this, there is a poor correlation between the ammonia levels and the severity of liver disease. So getting the ammonia levels is not actually a good diagnostic test to check for hepatic encephalopathy and even to monitor the progression or improvement. Instead, we rely on our clinical judgment in diagnosing hepatic encephalopathy. So diagnosis is mainly clinical and supported by exclusion of other causes of altered mental status. So we should always rule out the possibility of stroke, hypoglycemia, maybe sepsis, uremia, and drug overdose. Now, this is the West Haven criteria for grading the severity of hepatic encephalopathy. So in grade 1, the symptoms are subtle. It can be as simple as alteration in sleep pattern. There can be a decrease in attention span. In grade 2, there can be behavioral and personality changes. There can be lethargy. Patients are still able to cooperate at this time, so you can check for asterixis or liver flap. So this can be elicited by having patients extend their arms and bend their wrist back. And those who have hepatic encephalopathy have a liver flap. So that would be a sudden forward movement of the wrist. That is asterixis. For grade 3, the patient will be asleep most of the time, but they can be responsive, but often they are disoriented. And the worst is the patient can eventually go into coma. So like hepatorenal syndrome, there are factors that precipitate hepatic encephalopathy. And just take a look at this table. So the usual culprits are infections, electrolyte disorder, yes, gastrointestinal bleeding, and even constipation. Okay, so for the treatment of hepatic encephalopathy, first we treat the precipitating factors. Okay, so I've discussed this before with hepatorenal syndrome. And the next is we try to reduce the production and absorption of ammonia. And the first line is a non-absorbable disaccharide. So this is lactulose. Okay, so lactulose lowers the colonic pH. So this traps ammonia as NH4, which is non-absorbable. And it also acts as a cathartic. So it reduces the intestinal transit time. The goal when giving lactulose in a patient with hepatic encephalopathy is to have at least 2 to 3 soft stools per day. So other treatment that are used are poorly absorbable antibiotics. So rifaximin. So rifaximin is being used a lot during the past few years. So this is usually an add-on to lactulose. This is a non-absorbable antibiotic that decreases ammonia-producing gut bacteria. And it has been shown to be very effective in preventing recurrent encephalopathy. Others that are used are a combination of neomycin and metronidazole. And for nutritional support, we give moderate protein intake. So we give protein at a dose of 1 to 1.5 grams per kilogram per day. Aside from cirrhosis affecting the kidneys, cirrhosis can also affect the lungs. So the first liver-lung syndrome that I'm going to discuss is the hepatopulmonary syndrome, or HPS. So HPS is characterized by arterial hypoxemia in a patient with cirrhosis without significant lung disease. Like HRS, in HPS there should be no pre-existing lung conditions, so the lungs are structurally normal. The liver causes intrapulmonary or the liver disease causes intrapulmonary vascular dilations, resulting in blood shunting past the alveoli and significant ventilation perfusion mismatch. Clinical symptoms include dyspnea and platypnea, or shortness of breath that worsens when the patient is upright and is relieved by lying down. Diagnosis of HPS includes demonstrating hypoxemia without evidence of significant lung disease and shunt on bubble echocardiography. Treatment is with oxygen supplementation and liver transplantation. The other liver-lung syndrome is portopulmonary hypertension. This is pulmonary hypertension in a patient with cirrhosis. The portal hypertension results in the production of vasoconstrictor substances like serotonin and endothelin 1 that affect the pulmonary artery. So over time, the pulmonary arteries will develop smooth muscle hypertrophy and fibrosis, which will then lead to the elevation of pulmonary vascular resistance, leading to pulmonary hypertension. Portopulmonary hypertension is rare, occurring in only 5% of patients with advanced cirrhosis. And for the signs and symptoms, many patients are asymptomatic, especially early in the disease, but they can later on develop dyspnea on exertion and fatigue. Diagnosis includes initial identification on echocardiogram and confirmation on right heart catheterization, showing elevated mean pulmonary artery pressure, elevated pulmonary vascular resistance, and normal pulmonary capillary wedge pressure. Patients with portopulmonary hypertension have a poor prognosis, and usually vasodilators are given to reduce the pulmonary artery pressure, and liver transplantation is advised. Next, we have malnutrition. We know that the liver is involved in the regulation of protein and energy metabolism in the body. So with cirrhosis, nutrition is a common problem. Patients with cirrhosis are usually catabolic and muscle protein is metabolized. So this will lead to loss of muscle mass or sarcopenia and sometimes fat stores. There are multiple factors that contribute to the malnutrition of cirrhosis. So these include poor dietary intake, alterations in gut nutrient absorption, and alteration in protein metabolism. General recommendations include multiple small meals, including a late evening snack with total calories of 25 to 30 kilocalories per kilogram of ideal body weight. Some even recommend higher caloric intake at 30 to 35 kilocalories per kilogram per day. And again, proteins do not have to be restricted, so we give it at 1.2 to 1.5 grams of protein per kilogram of ideal body weight per day. The late evening snacks are recommended in cirrhosis to prevent overnight fasting catabolism because
recording stopped. Recording in progress.
functions of the liver is synthesis of proteins, and this includes proteins involved in hemostasis. However, we should always remember that cirrhosis causes simultaneous decrease in both procoagulant and anticoagulant factors. So when the liver is damaged, both procoagulant and anticoagulant pathways are actually affected. So patients with cirrhosis, despite having the range result of prothrombin time, does not necessarily have that bleeding risk. So correction of INR using fresh frozen plasma is not really necessary unless the patient is actively bleeding or the procedure is a high-risk procedure for bleeding. In addition, patients may have thrombocytopenia from hypersplenism, but this thrombocytopenia is counterbalanced with an increased von Willebrand factor. Adequate thrombin formation can also occur with platelets from cirrhosis if the platelet count is more than 50,000 to 60,000. So the need for transfusion of platelet concentrate prior to procedures is only recommended if the platelet count is less than 50,000. And lastly, the synthesis of vitamin K dependent clotting factors 2, 7, 9, and 10 is diminished in patients with chronic cholestasis syndromes because 1. Absorption of vitamin K requires good bile flow, and second, fat absorption is impaired in cirrhosis, and vitamin K is a fat soluble vitamin. But fortunately, intravenous or intramuscular vitamin K can quickly correct this abnormality. I think this is my last slide.
Okay, so thank you for listening. I hope everyone's still awake. Any questions? If you have any questions, you can just unmute and just fire away. Anyway, before we adjourn, meron kasing just one question from your batchmates. So this is regarding coffee. No, so the question actually is, so Doc, just curious about coffee intake in NAFLD. Does it matter what kind of coffee? Because I was thinking if freshly brewed would be better compared to instant, or is the difference not that big? So to answer that, no, well, siguro first we have to be specific kung anong instant coffee. Okay? Kasi the benefit that we are talking about here is yung benefit ng black coffee or caffeine. So if you're talking about yung instant coffee na 3-in-1, the problem with that would be actually the caffeine content is very small and yung sugar content niya is very high. So siguro one sachet would have around 5 teaspoons of sugar at least, and some milk, no? So yun yung problem doon. So yung benefit is more doon sa caffeine. It doesn't matter if it's caffeinated or decaffeinated. It doesn't matter if brewed or not, although yung best evidence actually would be from brewed coffee. Okay? Pero if you are talking about yung instant coffee na black din, actually it still has benefit. Okay? Although a little lesser than the brewed coffee. Okay? So I hope I answered your question. Any more questions? All right, you're welcome.